the offices I'm at, there's 6 offices for Seaview Orthopaedics. The ones I'm at are Homedale, Ocean, Monroe, and Freehold. They're pretty much every week. My affiliations, we kind of went over some, certifications. Let's start the presentation. So I put this slide up here. This is just an anatomy of the foot. And the reason I put it up here is it shows you how intricate the foot is. 26 bones, 33 joints, a lot of ligaments, a lot of tendons, a lot can go wrong. And here's some of the real common see, and a lot of you have experienced some of these things. And there'll be time at the end for questions. I'm sure there'll be some. One of the most common things that comes through the door on a daily basis for me is just the average person complaining of heel pain or plantar fasciitis. Generally, this is going to be pain in the bottom of the foot. And what causes the plantar fasciitis inflammation ligament that runs the course of the bottom of the foot. And reasons that you might develop inflammation there, prolonged standing is a big one. We see a lot of people who stand in retail, nurses, construction workers, come in with this problem. Weight. So whether it's weight gain or whether you're a bit overweight, this stresses the foot. It will obviously stress the plantar fascia. Increase in normal activity. If all of a sudden you're walking many city blocks, that could set it off. And foot type. Some of it's just inherited. Achilles tightness. If you have a tight calf or a tight Achilles tendon, inevitably the bottom of your foot will actually try to compensate and stress a little bit more, and this can cause inflammation in the heel. So how do we actually diagnose this? A lot of it on clinical exam I can do pretty quickly and tell you that that's likely the problem. An x-ray will often pick up heel spurs, which is a good sign that this problem's been there for some time. And if we're not sure, we can always get an MRI or an ultrasound. How do we treat it? So I think I probably saw 4 or 5 patients today just for plantar fasciitis, and it's kind of the same across the board. We start you on a stretching regimen. There's some really good stretching that you can do for plantar fasciitis. And I even tell people, give yourself a little extra time beginning of the day or before you even slip out of bed and do some stretches. When all of that fails, a lot of times people are like, look, I've done all this stuff. I Googled it and this is what I've been doing. Steroid injection is really helpful in that area. It's a safe area to inject. It's not one where we're going to cause a lot of damage by putting steroids. So for me, that's one of the mainstays of treatment. Something called a night splint, and this will actually just kind of keep you stretched out, and you can wear it to bed. Put your foot at about 90 degrees, and we have those in the offices as well. Orthotics, this could be anything from an over-the-counter orthotic to the custom type. Obviously, as we go custom to your foot, we can make modifications, make sure the orthotic fits you just right, rather than something off the over-the-counter, which might be cheaply made or might not fit that well. Other treatment, physical therapy, icing, shockwave therapy, and lately PRP. I don't talk a lot about PRP, but this is the plasma-rich protein that's basically taking our own blood, spinning it down, and injecting it into the site. And then surgery, I would say somewhere around 9 in 10 people get better with just this conservative treatment. For that 1 in 10 who just doesn't get better, they do it all. There are some techniques. One of them we're going to go over real quick. It's called the TOPAZ. It's actually TOPAZ microablation. And the other technique is just a release of the plantar fascia. So this is a great slide actually. So this shows a model of what plantar fasciitis is, and also somebody who has a large heel spur. Obviously, the red area is where the bone has become inflamed. So the word plantar fasciitis would imply that it's actually an inflammation of the plantar fascia, the ligament. It's actually not. It's an inflammation of the bone itself. So the outside of your bone becomes very angry, and it's right where the plantar fascia is pulling all day long. Here's one of the main stretches that I have people do. I think that that TheraBand or towel. You can use a belt, whatever you have, you can improvise. But you're standing. You're not standing. You're sitting or laying down with your foot extended, and you're pulling the dorsiflexion. Force it. You want to get out to about knees. Feel that in your calf and your Achilles. It's also going to stretch the bottom of your foot. On top of that, we got the wall stretch here. You'll often see runners do this when they're done. Both hands are against the wall. You're going to bend that front knee, and you're, again, targeting the back calf, Achilles, and this will help loosen up the plantar fascia as well. There's a night splint. We were just talking about this earlier. That's a simple device. This one's a low profile one. Slips on the foot. This one's pretty comfortable. You can sleep in it, or if you don't tolerate it sleeping, you can wear it during periods of inactivity. We talked about the orthotics. In our offices, what we do for custom orthotics, we actually use a digital scan. So we'll scan your foot with digital technology, kind of saves a step from having to mail the product out and wait for someone to receive it and then get it back. This cuts down on the turnaround time, and we've been able to get very accurate scans. That's actually a picture of the system we use. That's the FootMax system for scanning the feet. This is real quick on the topaz microablation. So what is microablation? This is done in other parts of the body as well. It's done in the shoulder. It's done in the elbow. It can be done in the wrist. It's for areas where basically there's been chronic injury, usually to tendon or ligament. And we'll go in and we actually make these little pin tracks. There's no incisions whatsoever. And we go in with that little device, and it uses heat to actually punch little holes into the target tissue. In this case, the target is the plantar fascia, and we'll make a whole grid on the bottom, and these little holes will essentially allow the body to come in and break up the scar tissue with the device, and allow the body to come in and fill in the holes with hopefully new tissue, or at least better tissue than what you had before. I'm sure anyone who's gone through life has had a sprain or a strain, but what exactly is that terminology? Sprain is implying that your ligaments were injured, whether they were stretched too far. That's a sprain. They could tear. And then you have a strain, which is of the tendon. What's a tendon? The tendon connects our muscles to the bone. Okay, so there'll be a quiz on this slide at the end of the lecture, so everyone take notes on this one. So this is all the ligaments and tendons in the foot and the ankle. And again, I just put it up in there to show you how intricate the foot and ankle is. It's not just a collection of bones, it's a collection of bones and soft tissue. So I have the scenario a lot of times where someone comes into my office and they said, well, I already had x-rays, and I was in the ER and I was in the urgent care and I had x-rays, and they said there's no breaks and everything's fine. Well, the x-ray just showed us that there's no breaks. It doesn't mean everything's necessarily fine. The only way to look at these more intricate soft tissue is with other imaging. So this leads into this slide. X-ray, let's think bone. You can see some soft tissue, but overall we're looking at bone. A CT scan, this is a very detailed three-dimensional look. We're going to still be looking at more bone and cartilage, but we can pick up some soft tissue. So better than an x-ray for soft tissue, not ideal, but much better for bone and cartilage. An ultrasound, this is okay for certain types of injuries. I don't order a lot of ultrasounds. I'm more using them to look at blood vessels. If you've ever had an arterial or a venous Doppler, you can look for clots with them. That's usually what I'm using them for. And then the MRI, this is kind of the gold standard if we're looking for ligament, tendon injuries, if we're looking for tears, sprains, strains, an MRI is the way to go. So a lot of times when I recommend that somebody do an MRI, the first thing they'll say is, I can't do an MRI, I'm claustrophobic, or I don't want to go in, or I have to be sedated, or something, and that's a real problem. Being claustrophobic is a real thing, and luckily there are many facilities that have open MRIs. This is a great example of one. You can see the person is listening to music, which is actually usually the case, and laying with their body outside, but their foot and their leg in the machine, which I think for most people, they wouldn't become claustrophobic in this setting. An ankle sprain, again, very, very common. So how do we diagnose? Obviously, the story, the clinical exam. We could order an MRI. The treatment, this is the treatment for a lot of initial injuries, the old mnemonic RICE, rest, ice, compression, elevation. And this goes for most acute injuries. This is how you should start treating at home. And then if things don't get better, you come see the specialist. Surgical treatment, obviously, if you tear ligaments or tendons, that's can always be fixed. Ankle joint arthritis. So osteoarthritis, it doesn't have to just be in the ankle joint, it could be anywhere. And this is damage to the cartilage. It's that simple, whether it's from wear and tear or whether you sustained an injury early in life, late in life, anytime, or you just have some bad genetics, the cartilage will break down, and all of a sudden you'll notice that your joints aren't moving as well. They become fatigued and painful and swollen. And usually motion is what sets off really bad arthritis, does not do well with motion. So symptoms, pain, stiffness, limited motion, swelling, that grating sensation, which we call crepitus, and bone spurs would be seen on x-ray, or sometimes you can even feel them right through the skin. So who's at risk? Everyone's potentially at risk, but age comes into play here. So the older you get, the more you go through life, you sustain little micro injuries, and body gives way a little bit and the cartilage will tell you about it. Obviously, again, we target on weight here. If you're carrying extra weight, they stress the joints a little bit more. Injuries, occupation, of course, genetics, and other things such as gout. If you're prone to gouty attacks, that's a joint destructive disorder. Something like rheumatoid arthritis is potentially joint destructive. How do we find out if you have arthritis? X-ray, again, we're looking simple two-dimensional image of bone. We could step it up with an MRI, a CT scan, and diagnostic injection. So this is kind of an interesting one where often injections are given because we want to make things better. We want to alleviate pain, bring down pain. But sometimes we're not positive. Is the pain coming from your ankle? Is it coming from somewhere else? So if we inject into your joint, even if we don't use a steroid, if we use something like lidocaine, and all of a sudden you say, oh my God, my pain's gone, we know that's where your pain's coming from. You can actually save some steps in the treatment process just by figuring out where exactly is the pain originating from. Treatment for arthritis, there's no perfect cure for most arthritis, but anti-inflammatories, physical therapy can help to strengthen the surrounding areas. Injections, whether it's steroid or PRP, or there's some other substances used in the knee that can be done. And then joint arthroscopy on the surgical side for simple arthritic conditions. We can repair cartilage, or we can at least improve cartilage. An ankle brace. I put this one up there. This is a really common brace that we use in the office. It's called a gauntlet brace. Probably some of you have worn it. It laces up and it does basically a figure of 8. I'll use this to treat some type of sprains. Also, some people do very well who just have arthritis, and they'll just kind of use it on an as-needed basis. You don't have to wear it all the time. Ankle arthroscopy. So what is arthroscopy? So for short, most people refer to arthroscopy as a scope. So your doctor might say, I want to do a knee scope or an ankle scope. What is this? So basically, in the ankle, we use 2 small incisions, one a little towards the outside, one a little towards the inside of the joint. And for the one, we go in with a camera, very small in the ankle, 2.7 millimeters. That's generally what I'm using. And then with the other hole, we'll go in with very small instrumentation, and it's hooked up to imaging where we can see in high definition what your joint looks like, extremely magnified. And then we can do anything from clearing out inflammatory tissue to actually repairing cartilage. The recovery on this is generally a 4 to 6 week period before I allow for normal activity. This study in the Journal of Bone and Joint Surgery, and I would say this is probably for more mild to moderate cases, resulted that the arthroscopic repair of cartilage lesions usually yields good to excellent results 93% of the time. I think that's right for those cases. If you have severe arthritis and someone's going to do a scope in your joint, you're not going to get better. It's really not even the treatment. Achilles tendonitis, another very common one. This is in the back of your heel. And this is one where the heel spur really does come into play. On the bottom of the foot, it's not quite as important, but on the back, most people who have Achilles tendonitis also will have a tightening, and they'll also develop a heel spur, which we'll see a couple pictures in a second. What's the difference between tendinitis and tendinosis? Tendinosis is actually the tendon becomes thicker. So tendinitis, it might be normal, but it's become inflamed for whatever reason. Tendinosis usually shows us that this problem's been going on for a long time, and all of a sudden your tendon has become scarred and thickened, and you can actually feel a lump there. Treatments, resting obviously for the acute injuries. Stretching can be helpful. Shoes, it's one of the few times we actually talk about wearing shoes that have a heel on them, not a high heel, but some type of support in the back that alleviate the tension on the Achilles. Anti-inflammatory creams can be helpful. I don't love them, but they can be helpful. That topaz procedure we talked about can be used on the Achilles, and then there is, of course, open repair. This is a good picture. So we see both things. We see the skin of somebody. You can see the Achilles tendon kind of bulging. Some of you might see that in this area, or you might actually see it further down in the back of your heel where the bone is. Could be from the tendon, and also could be from this giant heel spur that this person has. And even though that spur looks huge, a lot of people have spurs of that size. I see it all day, every day. Switching gears, we're going into bunions. What is a bunion? Basically, it's not just an overgrowth of bone. It's the first metatarsal. The bone behind the big toe usually goes outwards, and in relation to that, the big toe goes inwards. And at the apex is your bunion. We can obviously see this just by looking at your foot. X-rays tell us just how good or bad it is. And how do we treat? Obviously, wider shoes just to alleviate some of the pressure. There are bunion splints. They do not correct the problem, but they could put your toe into a slightly better position. Orthotics can be helpful for someone who's flat-footed, and that's one of the causes of bunions. And then there's the surgical repair. This is a good look at what a bunion is. We see both the person's foot. You probably know somebody, or you might be looking at your own feet right now saying, I have that. That's a bunion. And it's not just the overgrowth of bone. If you look at this person's x-ray, you can see their first metatarsal is actually shifted outwards and is pushing up on the skin. And you can see the deviation between the two lines, they're not parallel anymore. All the other bones look pretty parallel, and the first metatarsal is somewhere out in right field. There's a little before and after of somebody who had bunion and hammertoes. We'll get into hammertoes in a second. Good nail polish job as well, but this is a nice correction on the bunion. You can see it straightened out. The hammertoes are straightened out. What are hammertoes? These are basically contractures in your toes. So you might see that the toes are kind of contracted, sticking up. Might actually start to form little calluses on them. They can become painful when they rub on your shoes. What causes them? Sometimes it's just your foot type. They're handed down to you. Other times, if there's neurological issues going on, you can get some contractures in the toes where the tendons on the bottom will overpower the ones on the top. Injuries can cause them. Different shoe wear can exacerbate the problem. Sometimes people who have diabetes actually will develop them too, and diabetes we'll get into as its own host of issues. We diagnose it clinically, and then I take an x-ray to basically look at your joints. The treatment, real simple. We can splint it, we can pad it, we can wear shoes that have a little more depth to it, and we can surgically repair them. Stress fracture is another good one. This will lead into osteoporosis. Stress fracture is basically when the bone has a small, teeny crack in it that might not even be detected on an x-ray. So right here it says it might be normal for 10 to 14 days on x-ray, and that's because x-rays are only so sensitive. A little teeny crack sometimes cannot be picked up by x-ray. Overuse injury, we'll see it even in younger people. They all of a sudden walk 10 miles and they usually walk 1 mile, or they go out and they jog for the first time in 5 years. That can actually cause overload of the bone and the bone to fatigue and give way. Weight, again, osteoporosis is a big one, and we'll talk about that in a minute. MRIs are really good at diagnosing stress fractures, but we generally don't order them right off the bat. The most common area is the second metatarsal neck. There's a good picture of it. That's the bone, the long bone behind your second toe. And usually just a course of immobilization will treat a stress fracture, and that usually is a walking boot. Osteoporosis, though, if you're getting stress fractures because you have osteoporosis, this is a whole nother problem, and you can't just treat it with a boot. So what causes osteoporosis, and what is osteoporosis? So osteoporosis is basically your body is not meeting the demand of the bones. The bone mass is being lost faster than it's created. Generally, when we're younger, we're in good shape, or if we don't have underlying, disease, the body keeps up with the demand and it actually responds to pressure. Bones react to pressure and bone density reacts to pressure. So things that can accelerate osteoporosis as we get older, definitely. Women who are postmenopausal will go through hormone changes, which can lead to it. Hereditary, this is a big one, and being female, unfortunately, leads you to more osteoporosis. Lifestyle, if you live a sedentary lifestyle, the bones are not stressed as much as they probably should be. Diet is probably lesser. Certain medications can cause low bone density, and obviously certain diseases can as well, and treatments for certain cancers and stuff like that can as well. So symptoms, how do we know we have osteoporosis? You might notice that your height, you're not as tall as you once were. You might have sustained a fracture. We see them in the foot. Again, that second metatarsal, someone might come in and say, I know I didn't do anything. I didn't injure myself, but this bone is killing me. And we actually find out that they have osteoporosis. Oral steroids can cause it. Some people are on oral steroids for other problems, and they can cause it. Transplant patients and a drop in hormone level, which we talked about, postmenopausal females. X-rays can diagnose osteoporosis, not the most accurate, but we can tell something's going on. The bone density test, it's a dual energy X-ray, and usually we'll look at different parts of the body with this, the spine, the hip, and sometimes even into the lower extremity. And we can actually predict what your incidence of fracture will be based on your density. The bone density measures the amount of calcium and minerals in the body. A lot of people are concerned about the radiation, and you always should be concerned about radiation, but the bone density, interestingly enough, the radiation received in this scan is less than that from a flight from California to New York and back. So other things we don't think about is when you're on a plane, you're exposed to radiation. So I would argue that certain tests might be worth the benefits and outweigh the risk. How do we treat? Oral medication. The bisphosphonates have been out forever, but there's some newer medications now where sometimes it's a once a year injectable, sometimes it's a twice a year. There is hormone therapy, that's more for the females. And we didn't talk about, I guess, the most simple way. If you have osteopenia, not full-blown osteoporosis, this means the bone density is a little low. Vitamin D3 is really recommended as a supplement. This is a picture of a bone density machine. So who should have this test? According to the National Osteoporosis Foundation, these are the guidelines. All postmenopausal women age 65 who have risk factors. All women age 65 and older, women with medical conditions associated with osteoporosis, men who are older than 70, and then men 50 to 69 who have risk factors. Okay, we're almost there. Don't fall asleep yet. Diabetes, we'll go into, so type 1 or type 2, now more referred to as insulin dependent or non-insulin dependent. There's also gestational, which 2 to 5% of women will experience this form of diabetes during pregnancy. The cause of type 1 is generally thought to be hereditary insulin dependent, but it doesn't always have to be. Type 2 has more to do with lifestyle, and again, this is your diet and exercise, and hereditary and genes come into play here too. How do we diagnose? So it's not as simple as just taking your blood sugar and saying, well, it's this level, I have diabetes. The better way to figure that out is the hemoglobin A1C, which for anyone who has diabetes, your primary care physician is probably ordering this a couple times a year. And the level of 6.5 is kind of a broad level. Some people say it's 6, some people say 6.5. This is the average reading of your blood sugar over 3 months. It's a blood test. It's one you can't fool the test. Even if you ate a Snickers bar that day, it's not going to throw off the test by that much. I like this slide because it shows a doctor with a syringe and it says it wasn't really insulin, you don't have diabetes yet, it was just a warning shot. And we see these warning shots all the time in the office, and it might be someone develops a wound, someone develops numbness, tingling, and like all of a sudden we start seeing some of the signs of diabetes progressing. And that's kind of the warning shot that I give to people is, look, we're experiencing some things right now because your blood sugar is uncontrolled, and it's really important we find a way to control it, or there's going to be other consequences. Diabetic neuropathy is one of the big consequences of diabetes, and from poorly controlled diabetes or just having diabetes for a long time, you can experience numbness, burning, tingling, shooting pains, inability to detect temperatures, light touch. All of those things are signs of it. And this usually will begin in the feet, the legs, followed by the upper extremities. So that's my wife, how do we diagnose? Through a clinical exam. An EMG is a nerve conduction test, and I'll often send someone for a neurological consult if I think it's something a little more than that. Complications from it, we see diabetic ulcers all the time, and a lot of times they start because people can't feel their feet and they don't realize there's a problem brewing. Stress fractures is another one. You could be walking on an injured bone and all of a sudden come in with a big swollen foot, and we take an x-ray and diagnose some form of fracture. What's the treatment? There's oral medications that treat diabetic neuropathy. Metanex is more of a supplement. It's a B6, B12 folate supplement. These are basically nutrients for the nerves. It's more for mild neuropathy. For more severe neuropathy, Neurontin, gabapentin, Lyrica, they've all been around for a bit now, and those are the oral treatments. Diabetic shoes can be helpful for just a better fit, so we don't break down the skin, get pre-ulcerative lesions, or even develop ulcers. And obviously, diet and exercise. Some neuropathy can be reversed a bit if the blood sugar is well controlled and if you're more active. Venous insufficiency is another big one I see in the office. This is a swelling of the lower extremity, often at the ankles and the feet. And you also see color changes. You'll see that purplish staining. This is venous stasis, where basically there's been pooling of fluid in the area and the body releases a pigment which stains the skin. These can develop into ulcerations, and that's why we really do care about venous insufficiency. It can be full on its own, but it can also lead to blisters and ulcers. What causes it? There's a number of causes. I put blood clots and varicose veins in red because those are more serious causes of it. But things like obesity, pregnancy, smoking, trauma, family history, definitely. And you can get, some swelling of a vein that could cause it. Ultrasound or a venogram or venous Doppler is generally where we start with diagnosis. Make sure you don't have a clot. And then the treatment for simple venous insufficiency would be to elevate your legs, some form of compression, and this is below knee compression. Exercise, diuretics can be helpful. That's a water pill. And there are surgical procedures that vascular surgeons perform. It's a good look at venous stasis dermatitis. I often get asked by patients, what is this? Why is my skin turning colors? And can we reverse it? Unfortunately, we can reverse the swelling somewhat. We can at least make it better, but a lot of times the staining is there to stay. So this is one of the last slides. The recommendations. What do I recommend? I think anyone should, make a habit of checking their feet daily, especially if you're a diabetic. I think it's necessary. Exercise and diet, more active lifestyle, less problems. For diabetics, checking the blood sugar is really important. I'm always amazed at how many diabetics tell me they forgot to check their blood sugar that day or haven't checked it in weeks. And there's devices now that make it easier that hook up with your phone. I don't really see the reasons we can't check them anymore. The HbA1c is usually performed every 6 months, and that's that 3-month blood sugar reading. Diabetic shoes can be helpful to prevent breakdown of the skin. And then just a lot of diabetics will go to their podiatrist for routine foot care, and not only will they get their nails and their calluses, trimmed, but they'll also have a good look. Someone to take a good look at the feet and prevent problems from happening. And then the last thing, don't wait. I think this goes for all problems I see. A lot of issues and treatments could be simpler if patients didn't wait to get them checked out. It's a picture of my kids, 7, 5, and 1. This is Caden, Callie, and Quinn. And that's the end of the presentation. Again, those are our offices. And I think we will open it up to questions.
To open it up to questions, please just unmute yourself. We muted everybody, so just unmute yourself using that little tiny microphone next to your name, or the chat if you feel more comfortable.
Question: how is glucosamine and chondroitin for joints in the ankle? Does it have any healing powers?
Does chondroitin have healing powers for joints? Is that what your question was?
Yes, the glucosamine and chondroitin.
Oh, glucosamine and chondroitin. Yeah, so I think both of those can be helpful for treatment for those problems. However, I think they work better on the mild arthritic cases. So if you have mild arthritis, I think that's an excellent supplement to take, and I think I would recommend it as long as there's no kidney problems or something preventing you from taking it. But I think when you get to the more moderate to severe, those are not going to be as helpful. It's why knee surgeons are injecting different types of allografts into the knee for that reason. But for mild cases, yeah, I think it's helpful.
Okay, one other question. What about
Yes.
non-diabetic neuropathy?
Yeah, that's a good one. So probably should be included in my slide. So number 1 cause of neuropathy is diabetes, but the number 2 cause is actually the back. So the spine has all of our nerves in it. So our feet are hypersensitive, lots of small nerve endings, and they'll pick up on abnormal changes in nerves first. So a lot of times if someone has spinal stenosis, a herniated disc, they've had an injury at work, they might start experiencing tingling, burning, numbness in their feet. And a lot of times we find it's coming from the spine. So the treatments might differ because you might have a problem in your back that needs to be addressed. So I often work with a spine surgeon. I'll say, hey, at the very least, see a spine surgeon, get some x-rays, get an exam, and let's see if this is originating from your back. That test we talked about, the EMG, that nerve conduction test will also show where it originates from.
Thank you, Dr. Hersh.
Of course.
We have a question in the chat from Sandy. Treatment for capsulitis of the foot.
So that's a broad term, capsulitis. So capsulitis is generally referring to joint pain. That's usually in the metatarsal phalangeal joint. Some people will develop inflammation in that joint space. So I guess I would follow up with a question and just probably ask how it was diagnosed. I would tend, if you're getting diagnosed with capsulitis, I'm wondering if there was an MRI already ordered.
I have a question. My right foot, I had my left knee replaced last October, and since I say about March, my right foot is a little sore, and I don't know, it's because maybe having favoring the left leg, now my right foot sore, and my right ankle was dislocated in 2005, and I know I should come in, but I'm busy and I should make an appointment.
Yeah, so I think definitely we see that all the time. Somebody has knee surgery or someone has knee pain and they just start walking differently. And it's not something you're doing on purpose. It's kind of a subconscious thing the body does to guard, and you start to develop a new problem. Obviously, if you had the ankle dislocation, either bones broke or ligaments tore. So that's a whole nother problem. Anyone who breaks their ankle or dislocates their ankle has a severely increased risk of arthritis in the joint. So
I do have rheumatoid arthritis also.
oh, and there you go. So rheumatoid arthritis affects the joints. So you have like the trifecta of problems there. You have rheumatoid, you have a previous injury, and you have the knee. So usually someone with yourself, we start with just routine x-rays and exam, and then we decide whether we need to get a more detailed exam after that.
So I'll call the office tomorrow and make an appointment for to see you.
No, of course. I would love to see it. We'll check you out.
Okay.
A question from our email. I sprained my left foot bowling last fall. I stopped bowling because the arch and bone hurt. To stop at the foul line, I improved my shoes and began using copper fit arch bands. Occasionally, my foot still hurts to walk. What's the next step?
Yeah, so it sounds like to me we're dealing with some form. What was the beginning of the question again?
Basically that he
Bowling?
sprained his left foot bowling and that he switched shoes and used copper fit arch bands, but it still hurts to walk once in a while, so he's looking for next step.
Oh, I see. So yeah, I mean with the sprain, it's if you didn't, again, we talk a lot about detailed imaging, but a lot gets missed when people just go to urgent cares, or maybe they even go to their doctor and they get an x-ray and they're just kind of like, well, it's a sprain, you're okay. When we don't get that detailed imaging, a lot of times we miss things. And could have you had a partial tear at the time that is now healed, scarred? Do you have scar tissue in there? Have you developed arthritis? The next step is kind of the same as the first question. It's get x-rays, get exam, and then do you need a more detailed exam? Or is it something as simple as I say, you know what, this is plantar fasciitis, and you get a cortisone shot? It's tough to say without seeing it.
Any other questions from our participants? You'd have to unmute yourself in order to ask, or you can put it in the chat. I do have a question. I know you can buy compression socks, anywhere you go. So is there a specific brand that you would recommend, or is there a compression sock that's better for specific types of ailments?
I think that's a good question, because there is better, but there's also more difficult and most difficult, because the big problem that people have with compression is they can't get them on and off. So it's easy to recommend compression, but then the patient generally, not generally, but a lot of times will come back and say, I can't get these things on and I can't get them off, or I need someone to help me every time. So Jobst makes good compression stockings. They're like the leader. They're probably the #1 sellers. But there's also compression stockings that have zippers, and there's ones that wrap. So there's one called Circade, which actually wraps, and you can see from the wrap how many millimeters of mercury you've compressed. So the over-the-counters are generally 10 to 20 millimeters of mercury, and the only thing that differentiates them from prescription is they go up in compression. They'll go anywhere from 20 to 30 all the way up to like 50 to 60.
Okay, thank you for that. We have another question in the chat. Are there any ways to manage overlapping toes other than surgical intervention?
Not permanently. There's no braces or splints that will permanently correct them, but there are hammer toe or crossover toe splints that can temporarily improve the position of the toe. A lot of times if you have a crossover toe, it's pretty severe, and those won't help you. So unfortunately, yeah, it's surgery at that point, or you just kind of accommodate the foot. So one of the other things, and this is more of like a special order item, but you can order from different shoe companies. Not only do they make wider shoes, they actually make extra depth shoes. but you're generally not going to find those extra depth shoes in your shoe store. That's more of a special order product, but almost all the big companies carry extra depth shoes. You just have to look for them.
One more question. If hammer toe was already corrected, in quotation.
I see. So if a hammer toe is already corrected and it's still bothersome, there's different procedures that are done for hammer toes. So if it was a simple, what we call arthroplasty, where just a small part of the bone was removed, sometimes we'll actually convert that into a fusion. Other times it's more than just the hammer toe. You could have a ligament injury or tear on top of the hammer toe that's causing it to go up in the air. So sometimes that hammer toe is not all that needs to be addressed as far as surgery goes.
Any other questions from our group before we end for today? Let me give it a sec. I am at Seaview, we do these, we try to do these about every other month. We genuinely appreciate Dr. Hersh coming on today and giving us his knowledge and his time. And we appreciate all of you coming on and spending this time with us. It's a great way to connect with the community and do it from the comforts of our homes, which we love. One good thing that came out of the pandemic is that we all have access and know how to use these platforms. You can book an appointment online at www.seaviewortho.com. We do have access for you to see the availability of where you can book on Dr. Hersh's schedule if that is something that you would like to do. And again, he's at the Homedale, Ocean, Monroe, and Freehold locations. You can also give us a call, 732-660-6200. One more question, Dr. Hersh, before we end for today. It's a follow-up to the previous. So when would that surgical intervention need to be addressed prior to difficulty ambulating?
This is from the last follow-up to the last question about the hammer toe?
Yes.
When would it need to be addressed?
A surgical intervention. And then question prior to difficulty ambulating, question mark.
Okay, I'm a little unclear on the question, but I think the question is probably when would you surgically address a hammer toe that's been fixed and not responding to treatment? It's kind of a loaded question. I mean, it really just depends. If you just had the surgery 2 months ago, then it's probably something where anyone's going to tell you, let's give this a little more time. If it's something you had 2 years ago, or the position of the toe is visibly not in a good position, or you're forming some type of callus, then surgery is essentially elective. It's when you feel it's time. I always feel like my job is to give recommendations, and it's up to the patient whether they want to take them or ask questions on them. But it sounds elective to me.
Can I make one last comment, Seaview? It's always good to see you at the regional case management conferences. You man your booths with really knowledgeable and customer service people. It's good to see you there. Send more of your doctors out to talk to us, even if they're not presenting, but to be at your booth. You do a great job, and thank you.
Oh, thank you so much for that. Such a nice thing to say. Thank you.
Is there any chance we could get the slides sent to our email? I think there was something in the beginning about the recording would be, the slides would be great. I have several questions, way too many to ask. And I am a patient of Dr. DiPaolo every couple years for my knee, but yeah, I'm very interested in possibly seeing him make an appointment.
Yeah, I can send the slides to everybody. We can, Savannah is one of the marketing associates as well. She'll probably be the one sending it out, but it'll be the full deck of slides and also the recording. So if you missed part of it, where Dr. Hersh was explaining, we're going to upload it to a YouTube video where you'll be able to watch it again if you need to, or share it if you have somebody who might need that.
Okay, great. Thank you.
Of course. Thank you. Everyone, have a wonderful evening. Dr. Hersh, thank you again. And any questions, please feel free to send them to the email. And everyone, have a wonderful night.
Thank you.
Thanks, everyone. Thanks for coming out.
Take care.
Bye.